Good morning to all of you. With due regards to my teacher and thanks to us for the invite and the talk. We all know that SFIL has evolved from the time of the suture to the sutureless, or over time other various techniques like Yamanis and nowadays various indigenous SFIL techniques have come. In the old times, what we used to do is a railroad technique, in which we used to make the two flaps and then pass the suture underneath, and the tram track technique, which used to take these two sutures together. But there was some concerns in that you have to get the four ends there, then you have to tie the knots there, you don't get a scaffold behind there. And like in case of the opacities, like this, you are stuck somewhere. Like in this case, where one of my colleagues was trying to do a triple procedure, but unfortunately had a drop. So what we did a fragmentation followed by the technique which is called suture loop technique. How it is different? It's just make a flap, pass the needle directly from the flap to the main port. So there is no dealing with the sutures there. You just pass it through the eyelet, make a loop, and just guide it back to there. Doing the same thing on the other side, but there is a caution that you have to take the good measurement to avoid the tilt in such cases, and the job is done. If you have a support on one side, as you can see the de-enclaved ACL here, but there's support on one side, so you can place a suture on the one side and use the support on the other side. One of the indigenous SFL technique has been acknowledged by the American Academy of Ophthalmology, which is a very simplified sutureless SFL technique. I don't know whether the volume is not there, so I will explain. So there is no forceps, no glue, no haptic exposure.
Suture and can be performed through 3.2 millimeter clear corneal incision 2, center of the cornea and adjacent limbus marked accordingly. Localized peritomy performed. Infusion source applied. One can use the AC maintainer to scleral pockets fashioned parallel to limbus with right-handed directed inferiorly and left-handed superiorly to match haptics direction. 1.5 millimeter marks applied at the entry of pockets. 26G needle with silicone band segment prepared. 3.2 millimeter corneal entry made. Holder folder forceps. Injector or simple curved forceps to fold and deliver the IOL. Needle brought out taking care not to pierce any corneal tissue. Haptic threaded over 26G needle followed by IOL delivery. Haptic brought out and retained with the aid of silicone band segment, obviating the need of any assistant. Similar procedure performed on the other side. For haptic insertion, just hold anterior sleeve of the pocket and slide therein only to save off any haptic exposure. Port is hydrated and cautery applied to oppose conjunctiva. Compared to Yamanis, this technique has no trailing haptic issues. A hydrophobic lens is used. No glue or trained assistant for IOL injection is required. No haptic exposure or special forceps as Gerber-Sherritt forceps for haptic insertion is required.
Thankfully, this technique turned out the most commanded technique and for the persistent for the 7 months. And we all know that the Prolene sutures have been used commonly for the iododialysis repair and the fourth-throw pupiloplasty, as advised by Professor Agarwal. And apart from these, these sutures can be used for tackling the IOL tilts, subluxation, and in the cases of the anaradia, we can use it as scaffold suture. The idea came from this iron girder, I would say. You can place it centrally or the paracentrally according to the location of the tilt. Even the tilt up to 90 degree can be corrected with this. You see the lens is just standing perpendicular, staring at the cornea. So this small video, just make a perpendicular axis along the axis to the axis of the previous side of the tie. Localized peritomy is done, 1.5 millimeter mark. Thereafter you apply for. These are sites from where you will enter the eye. Thereafter, 3 to 4 millimeter behind makes scleral pockets slightly larger in size, but these are self-sealing, believe me. And thereafter, paracentesis is done to check for the orientation of the lens, that whether the lens is inverted or not, so that you can decide whether you want to pass the sutures behind or anterior to the lens. Then the simple technique of passing the suture, this Prolene suture, straight end from one side, reverse it back, and you're gonna take it from the other side. In this case, we passed it behind the lens, and thereafter titration, you bring it parallel to the iris planes, and the job is done. In cases, we have corrected the cylindrical power of almost up to 13 cylinder back to just 0.75 with these cases. And coming to the next, this is
on either side.
IOL pass-through suture or the junction fixation suture, rather than the lasso technique in which the people used to fix just the bag. In this technique, we pass this needle from the optic haptic junction from the substance of the IOL, and this provides much sturdier support. Done on both the sides, followed by the centration of the lens. Packs all the subluxated multifocal and toric IOL can be fixated. You can see that we have fixated this 62 lens back to the 62-degree axis, and the vision gain was good. Various multifocal lenses too have been fixated with this. This is a scaffold suture. I will be discussing two very interesting cases of the aniridia with this. Retina was incarcerated in the tear, believe me. And with this lens, the cornea was saved. Choroidal effusion, you can see for after silicone oil removal, the retina is settled, and the vision gain was 6/9 in this case. Another rare case of subretinal nucleus under the retinal detachment with the trauma, and this is the suture which saved the oil getting in touch with the cornea, and the patient gained a vision of 6/24 by settling, and there was glaucoma in this case. POBH, most of my pediatric colleagues do themselves, but they at times refer to us in case of like this PHPV. So what, after the placing the lens, just we use it as a support, sturdier support in these cases, and other uses are the anterior capsular extension, uveitis, trauma, and the scandiol placement. You can see that rexis is extended in this case, and the lens can be easily placed. In the uveitis case, especially in the VKS cases, are the chronic inflammatory cases where you want to avoid the capsular phimosis and the PCO formation. Keeping the lens away from the iris and the pro-inflammatory tissues makes a big difference in the post-op CME and the phimosis you have. Dialysis with the PC rent, or the cases of opaque IOL, you can use the POBH also. Just fashion the opening, and after explanting the lens, you can use it as a sturdy support. Nowadays, we are using it in the cases of the open globe injury with the repair cases, the closed globe injury cases, or in the membranectomy cases. You can do it with the posterior capsular rexis with the forceps, or you can do it with the help of the cutter, as you can see in the second case I was doing. And placing the lens therein only can provide much better and sturdier support. All of the benefits of the POBH can be used, I have explained already. Thank you so much for your patient hearing.
Fantastic, fantastic videos, really. You have shown so many different techniques in 7 minutes, really fantastic, and how you are able to manage everything. And any one or two quick points, Bharti or Ramurthy or Navalkar? Yeah. Only the scleral tuck, no, what you do is just tuck the haptic into the sclera.
Yes,
then
sir.
how do you close that flap? Do you put any glue or?
No, sir. So the flap heals by
Just put the conjunctiva and put the cautery, is it?
there's no need to place the flaps, sir, because if the...
No flaps?
No flap, I'm making scleral pockets, actually.
Oh, just a groove there.
Just a groove there, parallel to the limbus. On the right side, I direct it inferiorly. On the left side, I direct it superiorly to match the haptics direction, because the healing in the sclera is by the secondary intention. It's not by the primary healing. And secondly, in the cornea, what happens in the healing, the corneal fiber swells up to fill up the gap. But in the sclera, these fibers retract actually when you give an incision, and the blood there, along with the healing, the cells that go there, they produce those bridging sort of thing. And if the lens doesn't go anywhere in the 3 weeks, we have been doing this technique for almost 2 years and 4 years now, and done almost more than 200 cases. And our rates have been similar to the other cases reported. So it was just saving the glue, saving the forceps, and reducing the cost of the surgery, which, almost by the 10,000 per case. And the scleral SICS incision, many of my colleagues were not knowing how to do SICS. We are not trained in PGI even doing the SICS. Yeah. So they were having a hurdle in doing the SICS with the cross-knit and other techniques. So these techniques give a much better...
No problem. Thank you very much,
Thank
Pawan.
you, sir.
And
Thank you for the talk, Dr.